I am here to share with you the top 3 and best treatments to start with in preventive orthodontics. But today this video is practical. Today I want to share with you whether you are just starting in preventive interceptive orthodontics or already working with it, 3 excellent types of treatments. We will talk about the practical aspects, the indication, the activation of these devices, how you will manage the activation period. We will cover everything. But first, I want you to take a moment to leave a like on this video. Leave a like, subscribe to the channel. If you have been watching my videos for some time, you are already used to it. With likes, we can support the channel and all the structure that exists behind it. And it is important that you leave a like and also share this video with another colleague 2009, who is an orthodontist, so they can attend and share this knowledge. Loves, today I'm going to talk about these types of devices that are here on the table. We have the space regainer, we also have the Howley with an expansion screw, and we have the removable trap. These are the 3 devices that I will demonstrate in practice, the activation. So let's move on to our topic for today's video. First of all, dear ones, I want to bring up something that comes before the devices and before the treatment protocols. First, I want to talk to you about the important benefits of undergoing preventive interceptive orthodontic treatment. What are the benefits of treating with preventive interceptive orthodontics and indication, which is deciduous or mixed dentition? Well, first of all, we are going to have the potential to prevent these malocclusions at an early age where there is growth potential. So at this time, I can intervene and treat in a faster way, allowing the patient to grow, develop, and go through puberty and even adolescence, which is such a difficult period already with normal occlusion. So this will prevent problems in the future. It will prevent issues related to the functional and/or causal aspects. Therefore, this would be one of the greatest benefits. Second, we have the ability to reduce the complexity of these malocclusions for a second stage, which is corrective orthodontics. So, I managed to perform an interceptive treatment, with this treatment having a huge potential 2001 to reduce the period with braces, reduce the complexity of that treatment, such as in class 2, in Biorrheta bite, in class 3. So this ends up reducing the treatment time with braces, with less risk of cavities, white spots, so that is also done. Another very important advantage is that preventive orthodontics is capable of intercepting bad habits. So if this patient presents a self-destructive problem, whether it is digital or involves objects like a pacifier or something similar, we can intercept it at an early stage so that there is a regulation of the stomatognathix system post-habit interception before reaching corrective orthodontics, which is also excellent. Another significant advantage of interceptive orthodontics is that we can significantly improve aesthetic complaints and also symptoms of bullying at school for this patient at a very early age and effectively. Nowadays, our children are becoming increasingly sensitive to aesthetics, and it is extremely important that we carry out this treatment to prevent any psychosocial issues. So those are advantages that definitely make it worth starting treatment early. For a long, long time, it was spread that you had to wait until the age of 12 to start treatment, which is a lie. Okay, let's talk about our 3 treatment options. What would be the 3 most viable options, the best options for you to start with in preventive orthodontics? Remember, dear ones, that it is very important for you to participate in a study program, a diploma course, a course, or a specialty. However, along with the study program, it is also interesting for you to start with simpler cases and treatments so that you do not get discouraged, so that you understand this treatment plan in detail and do not have future problems. I have already changed clothes so that we can proceed with our clinical part. And loves, the first device I selected for you, and I will ask our editor to display it on the screen, is the device that is the removable expander. So you see that it is a Howley plate with a removable expander. In this patient, I used it because it was a type of posterior crossbite that was intraalveolar, not skeletal. So this type of device that is appearing here on the screen, as I am showing you, is a device that can be used, but it is not for all types of posterior crossbites. So take note that the indication for a posterior crossbite can be unilateral or bilateral, but it must be of intraalveolar origin. When you verify the parabolism of the arch, find its bony prominence, and find that those teeth are only lingualized, palatalized, and that only. A plate with an expansion screw can detilt those teeth. So, something very important for you to know about a removable expander is that it will cause a slow expansion of the maxilla and that this procedure is intraalveolar, not skeletal. That is why it is a good device for you to start preventive orthodontics treatments. But most of our patients actually have a skeletal problem. So a small percentage of cases will be indicated for a slow expansion of the maxilla and also have advantages. What would be the positive and negative points of using a removable expander? That is an expansion plate, a plate with an expansion screw. One advantage is that, number one, you do not need bands. So it is very interesting that you only need to take an impression and you can already design the device as shown in the model without the need for bands. Therefore, it is easy to handle. A positive point is that it is easy to handle. Another positive point is that you can easily add some accessories. So, as you can see here, I have an Adams clasp in the composition of the device, and I have a C-clasp for retention. I also have a vestibular arch with 2 activation omegas. So, on both sides. And also, in addition to the expansion screw, I added this spring which aims to vestibularize my central incisor. So I have to vestibularize tooth 11. I make an activation spring, and also when I see that there is a deep bite and it will be difficult to uncross this incisor. I can also add bite lifts with an acrylic coating on the occlusal part. So there are many possibilities with these expansion plates. But what would be the negative points of using that type of expansion plate, the removable expander? Number one, as I already told you, we cannot work with malocclusions of skeletal origin because this movement is entirely intraalveolar. So I cannot open the mid-palatal suture with a removable expander. I do not get orthopedic responses with that type of device. The second negative point of working with this type of device is that we completely rely on the patient's cooperation. So if the patient does not cooperate, there is no positive effect from the device. So if the patient is not cooperative, they do not use that type of device. Okay, another disadvantage is that if the patient does not take care of the device, we will have problems and accidents. Like I already had a patient whose dog ate the device, and another who placed it in a napkin and it ended up in the trash. So from the many stories I have already heard about poor care with the device, the family must be very well guided to avoid this type of problem. Okay, regarding types of activation, I consider activation as something we need to do independent of the activation of this spring, but something we need to do at every appointment with removable appliances would be number one, to control retention. So, do I always come and tighten these loops of the Adams clasp, making sure they are directed correctly? I am using a 2-prong plier. Is that all right, dears? So I am going to apply this pressure in such a way that these ons of the Adams clasp enter the most cervical part, the part that is the most cervical of the deciduous teeth. So you see that nowadays I use the second deciduous molars as anchorage much more frequently. The issue is that the second deciduous molars have an anatomy that is not favorable for us because the cervical part is not so narrow and the tooth does not have a shape where retention is good. That is why it is always important to perform this movement with the two-prong pliers, increasing the inclination of these small loops of the Adams clasp to enhance the retention of the device. Due to the characteristic of these molars, well, you will also increase the retention of these clasps in using. So always move these C-clasps back to increase retention. And the last activation you will do on this removable plate is in the mobilization of the looping. So sometimes I am interested in positioning. In fact, this omega is not a loopy. It is an omega. I am interested in positioning it further away from the vestibular surface of the incisors, or I am interested in positioning it closer to the vestibular surface of these incisors, depending on whether I want to vestibularize these incisors or leave a space free, or if I want to lingualize, palatalize, I want to change the inclination backward. So, depending on what I want, I can use the round part of the pliers to open this activation omega, or I can close this activation omega. Love, it is the second, very important and also essential device. One interesting and simple device for you to start within preventive orthodontics is ta-da, the removable lingual trap. Wow! The removable lingual trap is a lingual re-educator used and recommended for cases of anterior open bite. But what is an anterior open bite? An anterior open bite is characterized by the absence of contact between the incisal edges of the upper and lower incisors. What happens is that for some reason, due to a habit or perhaps the tongue, these incisors ended up interrupting their normal eruption path, and since this path was interrupted, it left these incisors an infraocclusion, causing an anterior open bite. So, dear ones, how can we improve and treat this malocclusion? We must work with lingual re-educators, and the lingual re-educators can be fixed or removable. What happens is that devices like this one I am showing you are excellent options if the patient has already abandoned the habit. Okay, Professor, so does that mean the removable trap is just to break the habit? Yes. So, if your patient has already abandoned the sucking habit and still has an anterior open bite, this is an excellent treatment option. Now, if your patient still hasn't given up the habit, do not attempt to treat with removable trauma. What won't work? What do you think is stronger, a removable expander or the habit that the child loves, that the child is enchanted by? It's clear that it's a habit. He won't take his finger out of his mouth to place the trap. Or if he does that, he will remove the trap and put his finger back in his mouth. So, if the child has already stopped the habit, okay, we can do that type of treatment. Dears, so we have already seen the indication, and now we are going to look at the composition of this device. See that we have a retention class, a vestibular arch with two activation omegas. Here I can also have a different composition, without a vestibular arch and with retention clasps associated with that small activation spring. But my preference is that you always place the vestibular arch because it will function as a barrier, as a vestibulolingual guide for the upper incisors. Okay, With that in mind, let's think about the positive and negative points of the removable lingual trap. Positive points, and for me, in my opinion, it is something very important. A positive point of the removable lingual trap is that you can use this device while undergoing speech therapy. So, while you are treating the patient can also do speech therapy. What happens, my dears, is that speech therapy should be indicated from the moment the patient already has the closure of the anterior open bite, because the speech therapist or the phoniotrician will not be able to achieve the greatest success in their treatment if the anterior open bite has not yet been closed, has not yet been treated. So, it is interesting that when you bring in all the open bite and are maintaining the results, you are doing the retention of the results. The speech therapist can also be doing their treatment. So, for me, this is the best point. Second point, which is a completely positive point for all removable devices, is that the removable trap can indeed be accompanied by a lot of discomfort, because it is an uncomfortable region in the same anterior region. Another positive point is that the patient adapts well and complains less because they can remove the device. So, being removable, it is better for hygiene, adaptation, and patient complaints since the patient has become accustomed to using it. Okay. And I believe that we also have negative points. That's how everything in life is. Positive point, negative point. A negative point related to the removable expander is that it requires full cooperation. So, if the patient does not cooperate, it will not work. And another negative point is that I cannot use this device if the patient still has the habit. It can only be used if the patient has already abandoned the habit. These would be two negative points of the removable expander. With that in mind, my dears, let's go through the activation process again. I am with my best friend, the 2-prong pliers, which are wonderful. Before starting the activation process, I want my editor to show you how the clinical adaptation of this device looks. Taro, take advantage and show the doctors here how it works. So, look here at this clinical photo. The patient presents an anterior open bite intraalveolar caused by a habit where there is an opening of this bite in the anterior region from K9 to K9. And note that the patient was fitted with a removable trap that may or may not be associated with an expansion screw. For me, the expansion screw is essential because even if you don't need to perform expansion, you are activated to accompany the patient's growth. And well, you can see after the treatment that after 8 months of treatment, the patient already shows the closure of the anterior green bite. So, incredible, wonderful. Regarding the activations, we are going to perform the activations by also increasing the angulation by 45 degrees to enhance the retention of the device. And we can also activate these activation omegas. So I can place the round part of the pliers and reduce that omega, mainly because in anterior open bite, the patient will need this lingualization, this palatalization, to help in the closure of the bite. Then I round off the tips and close the activation omegas. Important, loves. This anterior loop should not be too close to the incisal third of these upper incisors. Okay. So always check the height of this anterior segment of the vestibular arch in relation to the crowns. All right, my dears, let's move on to our last device. Last device. Nicholas, do you think this video is going to be good? Are the doctors going to like it? Yes, yes. Okay, Nicholas doesn't want to talk much with you today, but let's go, keep going. So, for our last device that I am going to recommend for you, who is starting in preventive orthodontics, our last device is a space retainer. There are many types of space maintainers, but this is one of my favorites. Okay, there are types of space maintainers, my dears, that are fixed, such as in this case of my patient Maria Clara, where I performed isodontia on a first molar that was in infraocclusion, that was ankylosed, and there was a tremendous amount of work. To perform this isodontia, I had to segment the girl's tooth into 3 parts, and you can see that she had that tooth ankylosed. I removed it. She went a month without retention because her mother couldn't bring her. A month without retention, and we lost the space for the premolar. And I clarify that it could be worse because I already saw her a month ago. Here is the x-ray. I am going to ask Carol to place the first x-ray, which is from the beginning, and the second x-ray, which is from a month later when I lost the space and now I have to recover it. Well, dear ones, in the case of my patient, since she was already quite advanced with corrective orthodontics and it is a specific treatment, I preferred to retain the space with brackets and a spring. So if you are already at the end of the mixed dentition phase and are about to start corrective treatment, you can already proceed with treatment using brackets and springs. But there are cases where you are in the early mixed dentition stage, and if you place brackets now, the patient will have to wear them for a long time. So what should be done in these cases? We can do this. We can achieve this space recovery with a removable device that will work very well for us. Observe here this removable device. That will be composed of a vestibular arch. This spring, which is the activation spring for space recovery, and some retention clasps. Like everything in life, we have advantages and disadvantages, positive and negative points. What would be the positive point of this device? A positive point is that you can use it from the beginning of the mixed dentition phase, so it doesn't matter if it is at the start of the mixed dentition phase. That is an advantage. Second, by not using brackets, you will not place and condition the vestibular surface of those teeth. Therefore, the preservation of the enamel structure is very important because a removable expander will be used and it will preserve all this structure and the characteristics of the dental enamel. A negative point, as with all collaborations. One point that is also negative for you to include in the treatment list is that when we activate this space regaining spring, sometimes this activation destabilizes the device. Therefore, it is advisable to activate it just a little so that the patient does not feel this maladaptation and the device does not come out of the mouth. So, one negative point is that I cannot activate it all at once. I have to make segmented activations until the space is fully recovered. Okay, so let's get to practice. Here we have our device. Our composition of the vestibular arch in the lower arch is optional. You do not necessarily need to do that. And we have the retention clasps, as you can see here, which are C-clasps. And the most important thing is the space recovery spring. Notice that this spring is almost passive. The patient will place it in the mouth, twist this spring, and fit it into place. So, how do I activate it? Professor, let's move on to the activation. I basically have a few activation points. So I place the round tip of the pliers. I will activate the device, and then I activate another segment to try to maintain this activation angle, and then I will compare. I will make a comparison on the plaster model to see how this activation is and check if it is not too active. The maximum activation you can do at a time is half the crown of the first molar. Okay. So, see here that I have half of the crown of the first molar for activation. And what you need to train the patient to do is to press this spring, force it, and leave it like that until it completes its action inside for a month. After 30 days, the patient returns so you can reactivate it. Okay. Oh, doctor, he is very active. He is destabilizing the device in my patient's mouth. So there's no problem. Come back with your 2-prong pliers so you can deactivate it, okay? And leave it a little less activated to improve the retention of the device in the mouth. We've reached the end of this video. I hope you have enjoyed it a lot. There are many other contents on the YouTube channel. Take the opportunity to watch and learn as well. Okay, see you next time.